Hi, welcome to BioMA's Coordinator Chronicles Healthcare from A to Z. My name is Brandis, and I have two lovely guests here with myself today. I have Danella Randles, and then I also have Diana Gomez. Everybody give them a round of applause. So I have been a biologic coordinator for 23 years, and in the upcoming years, we're going to be experiencing things that we have never experienced before. And so I brought an expert with me who is all things Medicare, IRAs, accumulator plans, and I just want her to kind of tell you all about herself.
Hi everyone, my name is Danella Randles, and I'm a former field reimbursement and access specialist, or FRM as most people call it. And I was a person who has a passion for patient advocacy and taking care of things of that nature. I have 6 brothers, 3 of which have Crohn's disease and end-stage kidney failure. And so it's really important for me to understand healthcare, and so I wanted to make sure that I'm able to assist them, because being the youngest of 7 children, a lot of things fall on me. So I wanted to be able to share that, and I love this. And so this job and doing the things that I do has really been a blessing, because I've been able to reach out and talk to a lot of different people about healthcare.
And then Diana, would you kind of tell us a little bit about yourself?
Hi, my name is Diana Gomez. I am originally from Colombia, and I have a background in healthcare for the last 10 to 15 years. But I only became a biologic coordinator in the last 2 years or so, and officially full term in the last year. Usually no, I started becoming involved because I'm always a patient advocate, and I found out that after moving here to the US, and I couldn't have the same profession that I had in my country, thanks to Brandis, that I was able to see that another way to help patients different than the way I was doing it before, and now I love it.
And just so you all know, her old profession, if you don't mind disclosing.
I was a doctor in my country, and due to certain situations, I didn't want to get my license here in the US, but I don't regret it.
You're a great advocate, so we appreciate all that you do. So let's go to Danella really fast, because we're going to have 2 parts here. Part A, we're going to talk about the accumulators, maximizer, optimizer plans. Part B, we're going to talk about IRA. Now, I can already tell you all, everything I've learned has been from this woman here when it comes to these plans. And even though Texas state legislation has banned a lot of these plans, like the accumulators, we still see a lot of them. And so can you kind of just explain why, and then kind of talk about the difference between the different plans?
Absolutely. So with the state plans, when the bans, and this is not just for Texas, this is for all states, there is a thing called self-funded plans, and self-funded plans are managed by or governed by the ERISA, or the Department of Labor. I'm sorry. Because of that, it trumps the state. So Fed always trumps state. That's the reason why we still see the accumulator plans. And so understanding what an accumulator is, it's a benefit. It's on your specialty tier of your pharmacy benefits. It's a device used by the PBMs in order to basically, like a good friend just mentioned, double dip, right? To get those funds twice. So once you utilize all the funds off of your savings card or your coupon, you exhaust that, then if you have not already met your deductible, then you still have to meet the deductible. So it's one of those things that creates a hardship for patients to stay on therapy, because they can't afford these medications. And so to kind of give you an example, say you have a $5,000 deductible, your drug costs $3,000, right? And the way it traditionally worked was, with your savings card, you would present it to your carrier. They would then take off say your deductible is $3,000, or I'm sorry, $5,000, the cost is $3,000, so that would leave $2,000. You use it, it would apply towards your deductible. The next time you go in for a fill, then it would take off the remainder of the deductible, and then it would pay part of your co-insurance. What's happening now, in the way they're working, if there is an accumulator attached to the specialty tier, they do not have to apply any of the benefits until your deductible is met. So they're taking the full cost of the drug off the savings card because you've not met your deductible. And it's so sad that even if you are still like $100 shy of meeting your deductible, they will still take the full cost of the medication off the savings card because you've not met the deductible. So none of those funds apply towards your out-of-pocket. And that's the reason why we're seeing a lot of issues with this type of thing, because patients can't afford those medications. They need them. I mean, they go through the process of getting it through their insurance and getting those approvals, but yet, because the manufacturer is helping them, then they're doing that.
I've had patients ask me, is there a way to kind of identify these plans, like verbiage in their insurance plans? Have you noticed any trends?
So if you check on, one of the places that they can look is on their summary of benefits. So when they go in and they sign up, like open enrollment for some people are still going on. When you look at your summary of benefits, it should state something in there, it's supposed to. Or you can ask the benefits person, hey, is this plan subject to an accumulator for specialty? I have a drug. Are my saving card funds going to be applied towards my deductible and out of pocket? If the answer is yes, you don't have an accumulator. If they say no, then you have an accumulator on your plan. It could be an accumulator. For the maximizer, one of the things that you'll notice is that it'll state that there's a third party that you need to contact, or a special number that you need to contact if you're on these higher cost medications. That's an indicator that it is a maximizer program.
So is there a way to be able to identify it before you pick the insurance plan then?
Like I said, in that there should be some verbiage and what you want to look out for, because they're not going to jump right out and tell you. It's not going to be in big bold. So you have to read the fine print, that little small print, get the microscope out and look at it and see if it states that, you may be responsible if you're using a savings card, or if you're using a manufacturer's copay card, or, something along those lines. Those funds may not be applied towards your out-of-pocket responsibility.
Okay. Now let's talk a little bit and shift about these maximizer plans, because there has been a trend now where some plans are requiring people to meet their deductible before kicking in, when I thought that was the whole reason that we had a maximizer plan, was so patients didn't have this out-of-pocket cost.
Yes, the really high deductible health plans. So with those, what we're seeing and what I've witnessed is that if they have a high deductible health plan, then based on some of the verbiage within the high deductible, it has to do with the IRS. And so some of that verbiage basically states that you cannot use or get assistance from any type of third party to help cover the deductible. You can use those savings cards and things of that nature to help with your out-of-pocket maximum, but you can't use it to help. You're responsible for paying for the coverage through the deductible. So when it comes down to maximizers have been deemed, and the reason why they're allowed to exist is because they have been considered a non-essential health benefit. Doesn't mean that the drug is not effective or it's not essential. It has to do with the ACA's determination of the 10 things that's covered under that's required to be covered under the plan, under an approved health plan. So some of these they've been given the opportunity to state they've been given the opportunity to state what's considered an essential health benefit. So they have deemed that the specialty tier on the specialty tier on the pharmacy benefit is deemed non-essential. Now, when it's non-essential, it's not subject to the deductible or the out-of-pocket. When you pay, you're just paying. It's not going to go towards your deductible or your out-of-pocket. So that's the reason why it's really difficult when they have these plans, because they can never, even if they don't go through this third party to set them up, the money that they pay will never be applied towards. So they can't meet their deductible with their high cost medication. So it's it's very, very difficult. Now, one of the things that I've also heard is that if they have a situation like this, they should be contacting their employer, and there may be some provisions. Not all plans do, but some employers do provide provisions for their patients when that happens. Some drug manufacturers will provide assistance and some won't, because they have coverage. They've received a prior authorization for it. And, you know, it's very difficult to come up off of $5,000 for the whole year, because again, it doesn't matter if your deductible is met or not. That drug, because it's considered non-essential, will never be applied. Now, once you do meet your deductible, then you know those third parties are supposed to pick up and pay at that, or assist at that time. But you know, how does that happen if you have a $5,000 deductible and the only thing that you have going on is that you're on a high cost drug? Your doctor's appointments and things of that nature are not going to total up to that amount. So it leaves a hardship for those patients.
There's a plan out there that even though you get the PA approved, the pharmacy will then send it off to that third party plan. And then that third party plan now does an authorization themselves, even though you've already got a prior auth done.
Yeah.
And then if they say no, does that just mean the patient can't get the drug?
So those are what you're referring to are those alternate funding programs, yeah. So basically what happens is there's a couple of things that can happen. So you get your prior authorization. It's good. You go in, they stop it, right? They want you to try and apply towards the patient assistance program. So most of the patient assistance programs, if they know that they're dealing with the alternate funding plan, 9 times out of 10, they're going to deny the patient on that program, because basically what they're saying is, I have insurance, I have coverage, but I don't want to pay for it. I'm going to make somebody else pay for it. Why have the coverage if you're not going to pay for it, right? Mm-hmm. So drug manufacturers are kicking those back and saying, we're not going to cover those. So then the patient needs to have something denying it. And at that point in time, then they go back and they say, hey, I can't get on this program, delaying the patient getting on therapy, because it takes time for them to complete the application, send it in, wait for them to make the decision. And, and that could take so that patient is now delayed on their therapy with this back and forth. And then, so a lot of times if they have a PA on file and they can't get them on the patient assistance program, then they will reverse their decision and allow that patient on the, for the plan to cover it. But again, it's a delay in the patient getting therapy.
Deanna, how have you been handling this?
I've been having a little bit of issues, and actually I was going to ask that question, because I've noticed with some of those alternative funding programs that I asked some questions recently about that, and exactly the same thing that you mentioned. And usually they tell us, or the suggestion that they tell us is, hey, let your patient know that to speak with the HR and speak with your employer so that they remove that, stuff like that. And so far, I do this recommendation to my patients, but the employer says that they can't do anything until the next enrollment, like the next open enrollment, which is kind of not okay. Because my understanding was that you could remove it even if it was not open enrollment. But it seems that now they're using this as an excuse for it to not be done. And as you mentioned, most of the patient assistance programs right now are including in the small lettering that if they're actually asking the question, are you being forced, or have you been told that you have to apply for the patient assistance program? Or they put in letters like they are not being accepted. And even in some other programs, they're not even able to use the copay card assistance. So we're having big issues on that regard. So how do I handle it? It depends case by case. Because so far I haven't been able to get anyone out of their alternate funding program, not gonna lie. So far I have not had any success in that department. The only thing I have able to have success is that at least the ones that are eligible to have the copay card is to re-review the copay card assistance, because they assume it's a third party, but it's in a third party as a maximizer. And as we know, some of them reduce the amount of money that is given to the patients, and just to take this as an accumulator in a way to see if that helps. And that's the only thing I have been able to do, to be honest.
It almost makes me feel terrible as an advocate, because sometimes I feel like I might as well get the prescription denied and get a patient on bridge. when you're dealing with these type of plans, that's kind of where it boils down to. It's like, do I get the drug approved or do I not get it approved? Yeah. And now I'm also running into, like, I have this one plan that I'm dealing with that no matter what I submit, it gets approved, but the patient can't afford it. Because it's like a $20,000, they have a $20,000 deductible. Wow. So it's like, what do? I mean, I can't even get anything denied because I could sit in the crappiest PA and it still gets approved. And I was just like, I don't know what else to do. Even the newer drugs, everything I have submitted has been approved on this plan. Like, what steps do you take?
And so it is an alternate funding. Have you tried submitting and taking that denial and trying to get it reversed?
Well, because it's all approved.
Well, no. When they tell the patient that they need to go through, the third party is telling them they need to go through the patient assistance program.
Well, this one, on this particular plan, they're not even telling them that. They're just saying, hey, it's approved. The patient goes use the copay card. They use it one time. That's it. But their deductible is so high, they still can't afford. I mean, they can't afford anything.
Yeah, usually with the ACA, unless they have like they're from a really small plan. Usually with the ACA, they state that the patient's total out-of-pocket shouldn't be more than $9,500. That's including the deductible and the out-of-pocket. But as we know, a lot of plans, they kind of deviate, or they use certain parameters to kind of go around the ACA. But they really shouldn't. I mean, a deductible should not be $20,000. Why have insurance at that point? Because you're basically paying for your.
Yeah, and they work in the oil field, so you would think that they would have a little bit better.
The other thing that I would suggest too is now is open enrollment. Check and make sure that these are, because a lot of times people get on plans because they're healthy and they want the cheapest thing. And one of the things that I would always say and suggest, especially when they, during this time, is to really look at the plans and see what's being offered. Because if they took a cheaper plan, out of pocket, that could be the reason why they have this $20,000 out of pocket. If they take an opportunity and look and see and do a little more research, although you may have to pay a little more out of your check. For me, I look at it like I'd rather pay a little more out of my paycheck than have to pay a whole lot out of my pocket.
Well, trust me, I understand.
You get used to, you get used to that amount coming out of your paycheck. But then when you have to come up off that huge dollar amount every time you need to get a prescription filled, that could be a hardship. And in that instance, the program, they don't have a patient assistance program, because that would be like one of those things where maybe they have a coverage, but it's still considered a hardship or with an affordability issue that they can't afford it, because I think they would much rather give a patient PAP than to have to pay that or, keep giving them medication.
Yeah, they'd rather somebody else eat the cost, basically. Yeah. Any questions from the audience about maximizers, accumulators, before we move to the next?
I would just say just to stipulate with the maximizer, and the way you can tell that it's a maximizer, again, it's the third party. A lot of people what they've been doing is just taking the savings card and exhausting the savings card, and then they get kind of caught in a bunch, because when they go to fill and then the drug manufacturer's not putting any more funds on their card. If you know that you have, if that writing is in that benefit summary, that's when you want to set up with the third party, because if that's the course you're going to take, because what they do and why they call it a maximum, because they consider maximizing, or it spreads out the funds from the savings card for the whole year. But if you go in and use the savings card all up in the beginning and there's nothing for them, a lot of times they may not even provide that assistance, because the reason why they wanted you to do it is the savings, and you've already exhausted it. So by starting off, when you first find out that you're on this drug and you first find out that you're on Maximizer, go ahead and sign up with that third party. That way, you can spread out those funds. I like saying that they're cousins, right? The accumulator and Maximizers, they're, accumulator is still the ugly stepbrother. It is. But the maximizer is not beautiful. I mean, she is kind of ugly too, especially when, like we were mentioning, it comes down to those high deductible health plans, because they were designed to help the patient or make it so that the patient would have that coverage. But again, it's considered a non-essential health benefit, and no matter how much they spend, and if they don't go through those third parties, they say they can end up paying anywhere from 30 to 50% of the cost of the medication. And even if they pay out of pocket, unlike the accumulator, with the maximizer, if they pay out of pocket, that money is not going to go towards their deductible or out of pocket. Accumulators, if they pay out of pocket, you can
put it towards it.
Right, and then you can also get that reimbursed through some plans.
And that's what I've told some patients who have the means, is to go ahead and pay for it. Like if we know you have an accumulator plan from previous, if you have a credit card, put it on a credit card, submit for reimbursement.
Exactly.
And that will take care of it. But then you run into that population of group who don't have the means, and then they're like, well, what do I do? And I'm like, well, I'll see you in June for samples. I mean, basically that's what happens.
Yeah, that's true.
It is true.
It's unfortunate.
So we're going to kind of flip the script a little bit and talk a little bit about the IRA that's coming up. Well, 2025, even though it's been in effect, since August 6, 2022 is when it was
2022?
signed.
Yeah.
This Inflation Reduction Act was signed. And trying to understand it, because I've had so many patients currently calling me and wanting to know, well, why do I have to pay my Part D plan and pay the 167 if I sign up in January for this payment plan? What we're calling it, the MP3 is what we're calling it now, I think. Can you explain a little bit about the IRA plan?
Well, I mean, there's different components to the IRA, the Inflation Reduction Act. So it encompassed a lot of different things, not just Medicare. But for Medicare, what it did was is supposed to reduce some of the spending and the cost that the patients have to pay out of pocket. And with this particular prescription payment plan, then basically, if you're a person that's receiving medication that's expensive and higher cost, where you could potentially meet your deductible or your out of pocket with the first fill, that would be a hardship, right? So what they wanted to do is to give them the opportunity to spread that out throughout the course of the year by contacting whoever your pharmacy benefits are managed through. Then you would reach out to them and let them know, hey, I want to spread my payment out through the year, and you may have to fill out some information and make that payment to them instead of making it to the pharmacy. The plan will then make sure that the pharmacy gets that payment. The other thing is with the IRA is the $2,000, right, out-of-pocket maximum. Where it used to be this year, I think it's like $8,000 the patient pays out of pocket, or a combined total of $8,000 the patient pays in the plan. Next year, I'm sorry, I bumped that. Next year, it will be it will look more like a commercial plan, right? You will have your deductible if your pharmacy benefit plan has a deductible to it, and if it's a specialty drug, you pay your co-insurance, and then once you meet that $2,000 out of pocket, then you will not have to pay anything for the rest of the year. But for those patients that can't afford that, they can spread that out based on what their drug cost is.
When these patients sign up for it, so say for instance, you're on a medication, you sign up for it, and then you drop off that medication in February or March. Say the medication's not working, but now you're still locked in.
Nope, you can get off anytime you want to.
You can get off anytime. But you're still going to be held liable for those funds.
Right. You will still be responsible for paying what you haven't paid in the past. And you can continue to pay until you have that paid off, but it's not something that you're required. It's not a requirement.
Okay.
Medicare is not requiring it. Now, some drug plans, like we were talking about, manufacturers may require that you sign up for it, but it's not a requirement from Medicare that you sign up for it.
Okay. Yeah, because I was reading they were saying that there would be some way that they could get the money back, and I was wondering, do you think that they'd take it from people like Social Security or something if they have adjudicated this $2,000 and then they stop paying?
It would be a debt, right?
Yeah.
There's a way. I'm
sure
thinking
there's a way.
that would be a way that they would take the money, because I was reading and they were saying that they're still held liable for the $2,000, even if you're not on the MP3 plan. So if you're not paying the 167, you come off the plan. The plan, they give you like a 2-month grace period is what they're supposed to give you.
Yeah.
Then if you don't make that payment, you're still held liable. So they would probably pull from wherever avenue that they can pull from to get that money back.
Right. So it's sort of like if you receive too many funds from Social Security, right? They will just kind of take taking,
been there.
pull it off.
I've been there.
Yeah, whatever it is, and they'll space it out and, and just take it straight from your benefits.
Take it straight from your benefits. Do you have any questions about the
What do you think about the removal of the donut hole?
What do you think about the removal of the donut hole?
For me, I think it was a really good thing. I mean, because there were so many people that didn't understand what was accomplished with the donut hole, right? And how to work that out. And so now it's pretty much straightforward, right? You have not all plans have a deductible, some do, some don't. It's pretty straightforward. If you have a co-insurance, usually it's looking like about 29% as the patient's responsibility on your specialty tier medication. If you are on low income subsidy, it's a benefit. For me, it's easier to understand. I know what's going on.
I don't know if the government's going to be ready for all of the people that are going to have to apply for LIS, because a lot of the patient assistance programs are making patients take that extra step to apply for LIS first before even looking at them for patient assistance.
But here's the thing, LIS, step away from the pride for a second. Low income subsidy can be such a good thing for patients because here's why. If they are approved for it, used to be 2 tiers, fully and then partial subsidy. Now it's just 1. And they went to 150%. It used to be 135% of FPL. Now it's 150% of FPL. They've also increased the amounts that you can have on hand. It used to be like 12 or 14,000, and now it's like 20-some thousand and 30,000 for a married couple. They don't take into account your home, what kind of car you drive. There's different things that they look at, but the main things as to when you were working that you paid for, they don't look at those things, right? And if you get approved for low income subsidy, it's a possibility that you can also qualify for additional Medicare savings programs, right? So you could free up the potential of being able to not have to pay your Medicare Part B deductible, your Medicare Part B premium. There are a lot of things that that will help with and putting more money back into your pocket. So, and then if you get on it, if you say the plan you select a Medicare Advantage plan, and you pay, you want a higher tier plan where you pay an additional premium. Being on that, it will reduce the premium. It will also reduce the deductible if you have a deductible on the plan. I believe it takes it away, so you don't even have to pay the deductible. So it is really. It's a matter of looking at going on, and the application is really easy. You can go on Social Security, ssa.gov, see, and it has the criteria there. A lot of the programs have it on a link where you can just click on the link and it'll pull it right up. The worst thing they can tell you is no. Mm-hmm. But when they say yes, there's so many more benefits.
Go ahead.
Can I just chime in? One of the other things that I want to mention, like she said, the out-of-pocket max is no longer 8,000, it's going to be 2,000. So I think that's another beneficial thing that's going to help patients. They're not going to have to try to reach that 8,000 out of pocket max anymore. $2,000, and then they should have the ability to be able to spread that out into a payment plan.
Absolutely, if that's the choice, because some people can afford it, right? They don't have to go that route. They depending on the situation. Some people can afford it, and if that's cool, then, because like I said, it looks more like a commercial plan now. Instead of having to worry about going to the initial, your true out of pocket, your initial, phase, then going into the donut hole, sticking around in there for a little while. And most people never really came. If they went into the donut hole, a lot of people didn't come out. So they ended up paying, depending on what drug they were on and things of that nature. So if you're on a higher tier drug, boom, you pretty much, like the drug I used to support, that first fill will cover that $2,000, and the rest of the year is covered at 100%. If you're a person that can afford to put that $2,000 on a credit card and pay it off over time, you're golden, because all the rest of your medications is now covered at 100%. So you don't have to worry about it. That's just your pharmacy. It has nothing to do with your medical. Even if you're on a Medicare Advantage, it's still going to be, pharmacy is still going to be separate.
I do have a question, and I mentioned to Brandis recently that now that the patient's assistance programs, some of them are requiring the patients to apply for the Medicare prescription payment plan in advance to even qualify for the patient assistance. And I had a patient that they called the plan, but the person that they spoke in the plan told them it will affect all your medications, which we already knew, but they told them that it was going to be more expensive for them, even though we knew that they were not going to really get the medication, because if it's not shipped, that means that they don't have to pay that medication. They just need it for them to apply. But we're having now this issue that they're telling the patients, like, don't do it. But then how do you explain that to the patients? Like to say, like, do we have to see all the medications that the patient has? Like, it's too much for just one person to try to explain that to a patient.
They might be not looking at the specialty medication that they're on. Because, this is what they're doing, and this is what the chart that I was given this past weekend was, if a patient is not on a specialty medication and they enroll, then they're going to almost pay double because they're now enrolled in this $2,000 when they really only owe $660. But if that person didn't come and say, hey, well, no, I'm also on a specialty medication, because there was no claims adjudicated, because they're probably on patient assistance. So if there's no claims adjudicated, then they don't know that they're on this specialty medication, so they need to be forefront and tell them, well, no, I'm also on this medicine, and this is about what it costs. Then now it's going to cost the patient the $2,000 that it's supposed to. But if they don't say that, then it's going to look like they're only owing $660.
Okay, that makes sense.
Yeah, because if you're only looking at generics or some brand medications, and it's not equating up to that 167, then it would be, because they still have to pay that 167 in order to be in that program. So if you're only looking at $50-$60, and then now with this spread out, then you have to pay 167, then that would definitely be an alarm.
And that was one of the issues we were talking about this past weekend, was like, well, how are these PBMs going to know to come to these patients who are on patient assistance if it's not for the pharma companies that are reaching out to them? So there's some companies that are being proactive and sending patients letters, but there's other companies that are not. And then that's where the problem's going to arise. And then how long does it take to get on LIS? I have a patient who has applied, but it's been almost 2 months and he hasn't heard anything yet.
I would say he should probably be calling, because it shouldn't be taking that long.
But I'm wondering if it's because they're having like this floodgate open.
I think a lot of things stop when it comes down to new programming, stops like from October to December. There's because like when you have a Medicare Advantage plan, right? So you sign up, open enrollment, October 15th through December 7th, right? You can add, if you're on Medicare, you can obtain January 1st through March 31st. Then if you would like to change you say you're on a Medicare Advantage, you went through a couple of months and you don't like it, you can switch it out, right? If you have a Part D, you can change your Part D from January through September for specific reasons. You can't just change it because you want to change it. There has to be a reason behind why you change it. So a lot of things with changes has to come in play between January and September. So I'm wondering if it fell in between the October and December, that may be the reason why they're slow. But I would say probably needs to call and follow up on it, because usually once you're approved, it's set up the following month, the first day of the next month, you should be able to roll into it.
Okay. Yeah, because a lot of the pharma companies are making patients now apply for LIS too, and if they get denied, then they'll look at them for patient assistance.
Yeah, because really what the patient assistance programs are designed for is to be the resource of last resort. You should be able to go through and, if you can get on a program that's going to help you with paying for it, that's what you want to do. We don't want to floodgate the manufacturers with people that, that really don't need the help when there are other provisions that can provide that assistance for them.
Okay. Now, you mentioned Medicare Advantage. I know a lot of us coordinators and advocates, we always hate the word advantage. That's probably a strong verbiage to use, but when we are always seeing issues on our end when it comes to Medicare Advantage, but you have had some positives. Can you?
Yeah, so I was at a program once, and I just heard this lady just kept bashing at Medicare Advantage, and it's like, but do you understand, why this is not what you think it is, because explain to me why you think it's so bad. And I could never really get a full answer as to why they thought, because here's the thing, if a patient signs up for Medicare Advantage, every patient is not going to be the same. You have to look at the situation and the circumstance. If you're on a drug that's covered through medical, and you can get, you're on there, Medicare may be the best choice for you, right? Because if you have a Medicare supplement, you can get it covered at 100%. You pay that, anywhere from, depending on when you sign up for it or what age you sign up for it, will determine on some of the plans how much you pay for it, right? And that may be good. If you're not, you don't go to the doctor that much, fine. But if you're a person that maybe a little more, you see the doctor a little more, or you may be in and out the hospital more, it would behoove them to really take a look at it, because for Part D, for Medicare Part A, I want to say it's like $1,600 that you have to pay up front before anything else is covered. That's a lot of money. With some of the Medicare Advantage plans, you may pay like my mom's is set up, she pays $125 for the first 20 days. And then after that is covered at 100%. From day 21 to day 90 is covered at 100%, right? So she pays $125. Some of the other plans may pay $250 from days 1 through 6, right? You also get the benefit of having a dental plan, vision, hearing. You get your gym membership, like they have what they call silver sneakers, or where you can have a gym membership. You're not going to get that under traditional Medicare. Some of the plans also have pretty decent out-of-pocket maximum. So like if you have Medicare and you don't have a supplement, you're going to be paying 20% until the end, right? From January to December 31st, you're going to be paying that 20%. If you have a Medicare Advantage plan, then like with my mom's plan, she has her out-of-pocket max is $3,900. So once she spends a total of $3,900 in the year, her plan covers everything for the rest of the year at 100%. You won't have that with Medicare. When it comes down to the Medicare Advantage, the PDP, or the pharmacy drug benefits plan, basically the same thing. You select the standalone. They're ran by some of the same insurances. So like you have Blue Cross Blue Shield, you have them as your Part D. You have Blue Cross Blue Shield Advantage. They're the same people basically, the standalone. And with the, now, when it comes down to, I have heard that with people with traditional Medicare, that it takes longer, it feels like it takes longer for them to get the decision when it's through an Advantage plan. I did read somewhere where they're supposed to be changing it from 14 days down to 7 days. So that should loosen up some of that concern about how long it takes to get the prior authorization approved. And things so those are that's really the biggest thing that I've heard with regards to with the Advantage plan, is that it may take a little longer. But if you I know some of you guys are really experienced in doing the prior authorizations, you have all your stuff on top and you're getting it in. Those people that are doing it may not be as experienced, because I was looking at some of the numbers. I was reading an article and they were saying that, but it's like out of the coverage, and when I pulled up the survey, it said only 20% of the people were dissatisfied with their Advantage plan. 20% out of 80%, out of 100%, that's not that much. That's not a lot. And then you have to think about who is it that they're polling, right? Because like as I mentioned to you earlier, my mother's been on Medicare since she started off with the Medicare Advantage plan in 2004. Okay. I have yet to get a phone call asking me survey questions about her experience with the Medicare Advantage plan. I have 3 brothers that are on Medicare right now, and one is on a Medicare Advantage plan. And I asked him, he has never been contacted, and asked about his, how things are going with his Medicare Advantage plan. So I don't know who these people are that they're surveying, but there's advantages. And again, you have to look at your Medicare Advantage plan, like with anything. it's not going to be everybody's cup of tea. So I would just say making sure that when you're going through, one of the best ways to find out what's truly covered, when you go through Medicare.gov, go in, select, if you see a plan that you're interested in, click on the link that takes you directly to the plan, not just the overview on Medicare.gov, but go directly to the plan. There's a thing called summary of benefits and evidence of benefits. You want to check out both of those, because that's where you're really going to find out what's covered in that plan. It will tell you what the specifics are as co-insurance. You know, it'll tell you what needs or requires a prior authorization. It kind of explains, the evidence of coverage kind of explains out what type of information that you need. So if you ever get a denial and it's for a Medicare Advantage plan, go to that plan, and usually on the card it'll have the number and it'll tell you what type of plan. Look that plan up and go, and that may even tell you what you need in order to be able to get that drug covered, because it will explain why, some of the nuances as to why, you know, what coverage is what coverage and things of that nature. So looking at that summary of benefits and the evidence of coverage will explain those things to you and will help you to make a more informed decision on which plan to select. Because the one on Medicare.gov, it kind of gives you, you know, it'll say 0 to 50, whereas you go to that summary of benefits or that summary of coverage, it will tell you exactly, you know, what it is that co-insurance, you know, what it'll be.
And I had a question for Medicare Advantage. Like, how are they going to be affected with the IRA, at least for the benefits for prescription? Are they going to have the same out of pocket, or are they going to have their own out of pocket? Because that's the kind of the issue that I was having Medicare Advantage, because it's hard to identify, because you have to go into each one to identify what is their out of pocket at the end of the day.
No, every Medicare Advantage plan will have a $2,000, every pharmacy benefit plan will be a $2,000 out of pocket. It's not because you have an advantage, it's all the same.
All across the board.
Yeah.
It makes it easier, at least.
Yeah. Now it may be, each plan may be different as far as what drugs they cover, because as long as they have a drug that's on the formulary, it doesn't matter, you know, the class, as long as they have a drug represented from the class is all that's required. They don't have to all cover the same drug.
I will say I am worried about a lot of the formulary changes happen in January, because if the drug is not on formulary for these patients for the IRA, the $2,000 doesn't matter. And the buzz is that there's going to be so many changes that are about to hit us in the face in January. I even was told about a couple of IL-17 drugs that are be taken off of some of our major plans.
That's why
that these patients are on currently. And they're coming to us and saying, hey, this is on my plan, but now I got to go back and tell them, oh, it's not going to be covered on formulary anymore.
That's why it's so important for them right now to be able to, if they're on an Advantage plan, it doesn't matter if they're on an Advantage plan or if they're on a standalone, they need to go on to Medicare.gov and put in their drugs, create an account, because when you create an account, it is housed right there. You can go in and pull up, and you know, it'll tell you a lot of information. Create that account, put all your drugs in there, and then go through and select the plans, because there's so many, like, deductibles may be increasing, right? Premiums may be changing. Now, per the IRA, they said that they can't go more than 6% or higher than, they can't increase these based on, you know, whims, where they can't just upcharge $30 or $40, $50 to the deductibles and things of that nature. I believe it's 6%. They can't go higher than 6% when they make these changes. But if you're not used to paying out of pocket, now your plan has a deductible. Used to be you could just let it ride. If you're cool with your plan and you know you don't do anything, you just let it roll over. It's really important that patients go in and they put their drugs in and see whether or not it's covered, because it'll let you know on the formulary, you know, for the following year, what's covered and what's not, because then, you know, you look for a plan that has that coverage. So yeah, and the other part is, like, if you get to January, and again, that January 1st to March 31st, they get in a plan and it's not covered in January, they are still eligible to change their plans. A Medicare patient with straight Medicare can't go in and change to an Advantage plan. They have to stay on that until open enrollment. But if they're on an Advantage plan, they can change it January 1st through March 31st.
Good to know.
Yeah.
Well, before we wrap up, I'm going to ask Deanna to kind of talk about some of the FPLs with the different pharma companies. Can you just kind of give us your overview? Because I know you've been keeping tally of what's changing and what's not.
That's true. So I have a very big Medicare population, and so I have to be very on the know on what the max caps and the minimum, of course. So all of the plans, all the programs so far have decided that across the board that they will have the minimum, which is the 150%, which is the application for LIS. All have to apply for LIS, and if they don't, and if they do and they're denied, they have to present that denial. How they apply, Donnell already mentioned how to do it, but I was going to mention that Medicare is complicated, and more so for the population that is already Medicare. Who are they? They are elderly, or they are people that have a type of a cognitive condition, or that they cannot completely fend off by themselves, and someone is taking care of them. And if it's a younger, probably an elderly person is taking care of them as well. So for them, it's very difficult to decide. Like, it's great that someone could help them to do what Donella mentioned, but themselves is very difficult. And some occasions I've been having to go with them directly to have in check what is it that they need to do, or what can or may work for the future. So going into this, not only they changed that, but also the income cap. So most of the plans before the IRA were 500% or 600% as the max cap. And this is taking into account the poverty guidelines. Not necessarily APL, but it's the poverty guidelines. And so only one of them had already changed in the last year and a half, I believe. They changed for this year because they were already preparing for it. But the others already came into it. And now we have this issue that even though the M3P can be good for some patients that can afford it, it's becoming a difficulty for the ones that require it. As I mentioned, that patient that now we have the issue that the insurance is telling them that they shouldn't get into it, and trying to tell the patient is like, hey, you're not eligible if you don't do this. So we have to find a way to get you on this, or you will have to do it this way. So it's reducing the things that we can do, and probably the patients are going to get annoyed. If not more on this population, they would say is like, I don't want to do all this paperwork, I don't want to do all this stuff, it just takes too long. It's like, I prefer to be off medication. So that is my concern. So 300, 400, it's not that much if you see
Under the federal poverty level?
Yes, so that's
400%.
300 versus 400% from the poverty guidelines.
Poverty guidelines.
Yes, and just one program has the 400%, if I'm real. Most of the rest have a 300%. There's one program that doesn't give you a cap, but you have to have the 3% of your income, which is the Bristol-Myers Squibb. We have to say that one, there's the 3% of the income, but recently they announced that it would be the 3% of the income, but taking into account the $2,000. So that's how they're going to manage it. For another program, you have to have the 4% of your income, so that way that you can, from the medication that you already use, to be even eligible. So it's harder, but I do understand that things are supposed to get better, but the difficulty that I am having at this time is because I handle at least more than 300 patients. So I am just one person trying to explain this to the patients. It is said that they were given like in the mail, they were explained and all this. It sounds amazing, but unfortunately, some of them have never received it or don't understand it. I am actually trying to take all the information that Donella is saying, because I'm trying to figure it out myself as well. So we are all in a learning experience, but I'm not gonna lie, it's very overwhelming.
I can imagine.
At this moment.
Especially with your older patients where they have no clue, they don't even know how to use a computer. Like I said, my mother's 95 years old, and if I didn't exist, and my brothers have no clue either, for her to be able to maneuver through those challenges would be, crazy. So we're very thankful and appreciative of having people like you, Deanna, where you can work with these patients and help them with maneuvering through some of these things, because it's not written to be understood. It's written to be confusing. So having someone that can take time to break that down and be able to assist these patients is amazing. And we're very appreciative of, you guys.
I kind of wish all pharma companies would just move to RTIPs, which is that soft credit check, because getting people to turn in income, oh my goodness. I had one person ask me, well, what you trying to do with my information? I'm like, I don't even want it. Like, you don't even have to give it to me. Give it directly to the pharma company and, let them handle it. But I wish that all pharma companies will go to the RTIP so we can avoid the back and forth paperwork and patients will know exactly where they are.
Yes, when I speak with my patients, what do? I have a laminated document with the current year's poverty guidelines, and then I don't even ask them like exactly. So I know that this is information that is private to you. I don't want a specific number. Just let me know. Is your household income below this amount? After I ask them how many people live in their household, is that are they because they take into account for the household income only if the money is shared. So for example, if you have a roommate or something like that they're not included.
I see a divorce coming on. I'm just kidding.
Yeah, those are not included. I learned that as well, that you don't have to request it from someone that doesn't really apply into the part of your economics. So that's how I can handle kind of the questions. Like just let me know, is it below this or is it above? You don't have to give me if you don't want to. I just need to check if you're eligible.
Should pharma companies put that back on their forms, the documents? Remember one company had, well, hey, if you make under this or put your income if it's between this, do you think we should go back to putting that on the company enrollment forms?
Some of them do put it at the beginning. But if we see in the practice, for example, I'm going to use the example of my practice. So since now dermatology is going into patient in, patient out, patient in, patient out, at least 5 minutes. So you start a biologic, sometimes the charts are not even able to be completed at that moment. And when they present the enrollment form or the patient assistance form, what do they have time for? The signature.
Just the signature.
That's it. And so what is the worth that first page if it's never going to be shown to the patient? The patient is not going to know until we are the ones that speak to them afterwards. So it's becoming quite difficult in the part that it needs to be fast. We need to move faster, but we are not having all the recourses to come in together. For example, I have a manufacturer right now that had that requirement, the M3P. And I asked when they spoke directly to the manufacturer, like I was working with the patient and they spoke with the manufacturer, but when they spoke with the case manager, they didn't emphasize on the importance of the requirements and how to handle that situation. So it's like, we are by ourselves then. And I did put this feedback with the manufacturers, like if they are not helping us on that end, then where are we standing with these patients? Because then they're not going to trust us, but they're not know who to trust at the end.
Yeah,
I think that a lot of the information, it needs to be a little more clearly defined, but because of so many regulations, it's really hard for them, especially when you're talking free goods, it's really hard for some of the manufacturers to put things in writing because of the nature of the type of program that it is, free goods programs. And so that's the reason why a lot of times you're not able to justify or be able to, your FRM may tell you or, so on, but it's not in writing and you need to have something in writing to share with the patient. But unfortunately, because of so many regulations, they can't put it in writing. It's just one of those things where, we try to work with you guys to help you with maneuvering through when those issues come up.
Yeah, my problem was that they speak with the manufacturer and those things have not been discussed with the case manager, so then it's the worst against us. So they're like, okay, this is what the manufacturer told us. Oh, but the manufacturer told me this. So it's like, okay, we have a situation here.
Yeah, there's those challenges, boy. I remember those.
Yes, and I know that we're all learning, and it's a learning experience. I do understand that, but it seems that we had enough time to prepare for it, and it seems that that preparation, I don't see it.
Fell by the wayside.
Yeah, I don't see that preparation, to be honest.
Yeah, and I think too, like I said, with a lot of the information sharing, like you were mentioning about the MP3, it's not really, unless you are in the know, those that are not in the know will not know. Because, or if you go to someplace where, like, you know, some of your clinics where they don't have time to sit and explain those things because they trying to get to see as many patients as they can. People fall through, and it's you know, I'm not a political person, but it's really difficult. Maneuvering through healthcare.
I will tell you, I always make a joke about the Medicare Advantage plans because I was trying to figure out always, like, how do all these patients get on them? And we were at my grandma's house one day, and literally she watches QVC. Every commercial was a Medicare Advantage plan. They need to do this for the MP3, make them like every commercial so patients understand exactly what's going on.
Exactly.
And
totally
they will
agree.
call and have more questions.
Yeah, no, and now what they will do is they'll have these people calling, but they're a service for fees, right? They're getting paid to do this. So they're not always going to tell you the best program or the best plan to get on. They just want you on whatever they're supporting, because I had to help my brother change. He was on they made this phone call and I kind of got mad. I'm like, this is what I do. I don't take the word of somebody on the phone. This is what I do. You know, to get him switched over because he was on this plan. And he was like, I don't know what's going on. And I'm like pulling up his plan. And I'm like, dude, why are you on this? Because it said that they told me. I'm like, no. So I may go. That may be my next business, going in helping people maneuver through Medicare.
Girl, you better make
Actually,
your
yes,
QVC commercial.
you should, because I immediately would send the patients there. I would send the patients there immediately. I'm not gonna lie, they do need a lot of help, and and I have to make, like, I don't have all the knowledge, like I don't have all the experience. For example, the experience that you both have. Like, I've been in this country for 7 years, and I only started learning about the healthcare system the last 3 years, because I felt that I felt incompetent at the time, because I was a medical assistant, but at that time I was still doing prior authorizations. Did they teach me how prior authorization works? No.
Did you get voluntold?
Yes. Yes, and anybody that goes into the healthcare system has no idea what is happening. More so the people that just came out of college. They say that they mentioned something about the healthcare system, and when I was mentioning something to them, because any information that I received, I like to share it. I'm that person that needs to blurt it out to someone else. And they're like, I never heard of that. You live here, you have this healthcare system that it's covering you and that probably you're going to be part of, like example, Medicare. And you don't even know what it has. Like, that's sad.
I didn't, to be honest with you, I didn't take interest. Like, I've always loved my job. I've always loved doing like biologics and coordinating, but I never took interest into actually diving into insurance plan until one day Danella and I had a conversation, and she came into my office and she was like, I saw one of these plans last year, and this was the first accumulator plans. This is when they started popping up, and you were like, no, I saw this pop up last year. And then that's when I started being like, wait, what? And then I would call her all the time. And like, you even taught me about how to go to like the healthcare website formulary to see what they will allow for tried and failed in order to have drugs actually on formulary. Did you know that you could do that? Like, she taught me how to go to United Healthcare's website, go to the formulary to look to see what biologics have tried and failed, or if a patient, like to keep a patient on one that's no longer on formulary. She taught me how to do that. So that's when I started diving in deeper.
Yeah, you go in and pull up the medical policy to see what the criteria is that needs to be met, and then utilizing that criteria to help with getting that, if it's a denial, getting that overturned. Because one of the things that was happening is patients switch insurances, right? It's not through an employer change, just because, well, they left one job and went to another one. And that new insurance is never processed that drug before. So they think it's the first time the patient is using it. So they fail them and say that, you can't use it, and you have to try these other drugs. Well, I had an approval, and I was on another plan, take that approval and submit it, or let them know that this patient, this is not new for this patient. Utilize that information so that they can get that drug
Use their
overturned.
guidelines too, because
Yeah.
like I went back in and I would have to state, well, per your guidelines, you said if the patient tried and failed 2 of these biologics, that then this non-formulated medication can actually be reviewed for the patient. And so she actually taught me how to go in and do that.
I learned it by Google. That's Google. But I do notice that it is hard to find those, like those guidelines are hard to find.
Oh, girl, call me. Google is my friend. I mean, that's my jam.
Or sometimes they're like, they are old, like they don't renew them.
You have to put the
They
year
have
in.
to.
When you put it in, you have to put the year in, and then once you get in, we'll talk about it.
Yeah, talk about it.
Well, I want to thank you all for coming, and I thank my audience for being here. You all have supported us to no other, so I appreciate it. And thank you for taking time out of your day to come and explain
Absolutely.
all of the things that we need to know about accumulators, maximizers, and the IRA plan.
Thank you so much.
Can we all give Danella a round of applause? Indiana.